Thank you, Chairperson, and I'm delighted to do the paternal contribution to this symposium in maternal medicine. And since two lady professors around, I try to do the paternal contribution. And my delivery is in the form of thyroid diseases during pregnancy. And during the next 20 minutes, I will take you through the pregnancy-associated changes in thyroid function tests and their interpretation, since it's important to know that there's a difference in the thyroid function test interpretation during pregnancy, and the practical issues in screening, diagnosis, and management of common thyroid disease during pregnancy relevant to the internist, as there are some relevant to surgeons as well, like thyroid nodules. So I will not be touching on that part. Now, the changes in thyroid function tests during pregnancy is summarized or highlighted in this slide. As you can see, in the first trimester, there is a rise in beta HCG, human chorionic gonadotropin levels. Along with that, there is a rise in the total thyroxine, which get sort of flattened and throughout the pregnancy remains same. And the TSH level, which we often use to screen both types of thyroid dysfunction, is lower, becomes very low during the first trimester and start rising in the second and comes to almost the non-pregnant level close to the delivery. So this is important to remember these facts. Now, why TSH goes down in first trimester is because HCG has an effect like TSH, and therefore it stimulates thyroid gland, and thyroid gland produces more thyroxine, thinking this is TSH that is pushing them to produce thyroxine, and this thyroxine go and inhibit TSH at the pituitary level. So as a result, for a given level of thyroxine in the first trimester, there's a reduced level of TSH, because during the first trimester, thyroid gland is stimulated not only by TSH, but also by HCG. So both are pushing them to secrete thyroxine, but the resultant secretion of thyroxine go and blocks the TSH. So TSH is lower in the first trimester. This is important. And start rising with T2 and T3. And the estimation of total T4, because thyroxine-free thyroxine, total thyroxine is a bound form, with the increase in the thyroid binding globulin with associated pregnancy, the total thyroxine remains same, elevated during pregnancy, and it is not a good indicator of thyroid function. And free thyroxine also goes down because of the increase in the thyroxine binding globulin in the T2 and T3. So these changes are important to be remembered. As a result, the thyroid function test interpretation is trimester specific. So TSH and FT4 cutoff values are trimester specific. And in T1, the upper limit of normal TSH is not as usual. You know, if anyone asks the normal thyroxine rate, most of them remember it's 0.4 to 4. You forget about the unit. It's a micro IU per ml. It's a 0.4 to 4. It's almost in this ultrasensitive TSH. So here it is lower. And free T4 is also low. And T2, it rises a bit, but T3, it's almost remained the same. What really matters is the upper limit of normal. But you might ask whether this 4 to 2.5 makes a big difference. It does. We'll see later. Why? The rationale is that they have reported that there's increased pregnancy loss in the mothers with TSH level about 2.5 to 5. So let's say 2.5 to 4, also there is an increased pregnancy loss, which is unexplained otherwise, thought to be due to the effect of hypothyroidism. right? So therefore, now it is important to use this reduced upper limit of normal TSH during pregnancy, especially during T1, where the pregnancy and loss occurs more due to hypothyroidism. Right. Then we'll get on to the screening. Now, thyroid diseases fulfill all the criteria for a disease to be screened universally. It is fairly common. You have an inexpensive screening test. Once screening and detected, you have an inexpensive thyroxine replacement, which will make you thyroid, and there are benefits. Should then we screen all pregnant mothers, expectant mothers with TSH? So this has been addressed at several levels, and there have been several reviews and meta-analysis on the universal screening. And currently in UK, there's an ongoing study on the continuous antenatal thyroid screening, CAT study. It has been there over the last 8 years. The continuous antenatal thyroid screening. You might wonder why such a long time. What they do is they screen and they follow up the newborns. And then they see whether those with hypothyroidism has any impact on the newborn during their childhood IQ scores even. They check whether those who have TSH levels this much during pregnancy, their IQ levels differ. So that's why it's continuous antenatal thyroid screening going in UK. And they sometimes produce reports and the literature on this. So the current advice is, based on that and other studies, that universal screening of a thyroid function is not indicated. And there are specific groups which might benefit from screening. If a woman has symptoms of hypothyroidism, definitely. But it will be very difficult to detect women with hypothyroidism being vague, you might argue. Because hypothyroidism symptoms are anyway vague, and women also, most of the time, they have aches and pains and sleepiness, and you don't know whether it's hypothyroidism or something else. So, but you have to use your clinical acumen to choose the correct person. Family history or personal history, obvious. Family or personal history of TPO stand for thyroid peroxidase antibodies. That is the antibody that is often checked, the thyroid microsomal antibody. It is available in the private sector, not in the government sector in Sri Lanka. Patient with type 1 diabetes has increased tendency to develop thyroid disease, that is recommended. History of head and neck irradiation, you know why, because of the irradiation damage to the thyroid gland. If somebody has recurrent miscarriages and impaired fertility, morbid obesity, and hyperemesis and clinical features suggestive of hyperthyroidism, because hyperemesis has an association with hyperthyroidism, not hypothyroidism, and any clinical symptoms suggestive of hyperthyroidism. These are the specific indications where screening is indicated, not universally. How common are the thyroid diseases in the community? Now, in Sri Lanka studies, we don't have a single study to say that in an antenatal clinic, this is the prevalence. But I had to depend on some literature from our neighboring country, India. It has to be recent. So this study has screened, even though universal screening is not recommended, they have screened consecutive 700 patients with TSH and FT4, and they found this prevalence rates of hypothyroidism, different categories among these antenatal mothers. And according to that study, the commonest form of thyroid dysfunction is subclinical hypothyroidism. And it's alarming to say that we just now saw the gestational diabetes is somewhere around 10, 12, with subclinical hypothyroidism a little more than that. You might wonder we should bother about subclinical. Yes, we do have to bother. And the other categories like overt hypothyroidism and subclinical hyperthyroidism and hypothyroidism. What you can see from this slide is that hypothyroidism is common than hyperthyroidism during pregnancy. And subclinical form is much more common. So therefore, when I talk about this hypothyroidism as a group, I thought of giving some importance to the group of subclinical hypothyroidism. Next, the hypothyroidism diagnosed first during pregnancy, and a previously hypothyroid mother who become pregnant. So, and these are the three categories of hypothyroid mothers that you might come across either on reports or might present to you as an internist. And subclinical hypothyroidism is the most prevalent thyroid dysfunction in pregnancy. And its prevalence varies from 5 to 15 in different studies. And it's defined as TSH level about 2.5 to 10 with normal free thyroxine. So this is the same. But the non-pregnant, we consider this as from 4 to 10 with normal FT4. In pregnant, we consider as 2.5 to 10 with normal FT4. And there are two types, as you can see in the non-pregnant levels. Non-pregnant women, there are thyroid peroxidase antibody positive and negative. And studies have shown that those with subclinical hypothyroidism with antibody positive do worse in terms of fetal outcome and also the maternal outcomes. And these are the maternal and fetal outcomes of different types of hypothyroidism. What you can see is that even the subclinical hypothyroid mothers have adverse outcomes like preeclampsia, preterm delivery, abortion, and also the fetal outcomes are also not the best. It may be less severe compared to the overt hypothyroidism, but they do have when compared to the euthyroid mothers. So it is important to recognize this category of subclinical hypothyroidism. And one preliminary study has looked at this, and what they have done is they have given thyroxine to mothers who are subclinically hypothyroid, and there's a category with TPO without thyroxine therapy, and there's a category with TPO negative hypothyroid. And what you see in this slide is the outcomes. The two outcomes, miscarriages and preterm deliveries, are less if the mothers with subclinical hypothyroidism with TPO positive given thyroxine. So this has led to the hypothesis that if a mother has a subclinical hypothyroidism with TPO positive, they will benefit from thyroxine, as in the case of non-pregnant. But here, the definition of subclinical hypothyroidism is a little different from the non-pregnant definition. So this led to the American Thyroid Association in its 2017 guidelines to recommend when TSH is above 2.5 with antibody positive during pregnancy and also pre-pregnancy. Sometimes when the obstetricians find no reason why somebody is subfertile, they do all the obstetric tests and then finally they find that some abnormality TSH, they land the patients with us, please advise. So you realize that TSH is high, or you also got to do something. So there's something that you can do. Luckily or unluckily, they may not have done TPO. So you can do TPO, and if it is positive, you can be a magician by giving little thyroxine and the mother hopefully becoming pregnant. Here, after so much of investigations, they ended up with a physician, and physicians with a small pill make them fertile. But ATA do not recommend the thyroxine in subclinical hypothyroidism who are TPO negative. They consider, that's a shared care. You can discuss with the mother and then discuss, look here, there is no definite benefit, and there have been some harm as well. So since there are no things to carry out now, the obstetrician has done all the tests and all this and that, and we can give a short course of thyroxine and see whether the conception can come. So it may or may not come. So therefore, ATA, American Thyroid Association, has only considered, asked you to consider. Patient with SCH will require lower dose of thyroxine. That is important. So don't give a very high dose, because thyroxine itself can make the mother hyperthyroid then. And there's a place for screening for thyroid peroxidase antibodies in TSH expectant women with subfertility and miscarriages. These are the lessons to learn. But subsequently, the latest on this topic is that also the same. So this article published recently in the BMJ Impact of levothyroxine therapy on the obstetrics, neonatal, childhood outcomes. I told you they are looking at the childhood outcome from the CAT study, continuous antenatal thyroid screening. They not only screen the antenatal period, they follow up the childhood outcomes, whether their IQs are different, any change. So it's a systematic review and meta-analysis along with that. So even though it's a sort of so seemed large study, the number on the 3 eligible trials are only less than 2,000 mothers. And in women with SCH during pregnancy, there was no evidence to benefit levothyroxine therapy on obstetric, neonatal, childhood, neurodevelopment outcomes. Mind you, this is TPO negatives. So they have not specifically said the TPO positives have benefit. So TPO negative subclinical hypothyroidism mothers do not benefit. That's the bottom line. Now, so hypothyroidism, if somebody become pregnant during, this is how it is diagnosed. TSH more than 2.5 with FT4 less than for that trimester, or TSH more than 10 irrespective of the free thyroxine. That's similar to non-pregnant diagnosis. So in such a situation, what do? You start common thyroxine with 100 to 150. This 2 micrograms per kg per day is a good dose schedule to go by, but you repeat as in any other non-pregnant, you adjust dose to achieve the trimester specific TSH. And it is important to tell the mother not to take calcium tablets and the iron tablets along with the thyroxine tablet. There may be problems with the absorption of thyroxine. If the pre-existing hypothyroid mother become pregnant, you have to assess TSH as soon as possible. And if TSH appear within the specific range, you can continue the same dose and repeat. If they are within this range, you may have to increase the dose accordingly, according to the TSH, if it is between 2.5 to 10 by 25 to 50%. And you may have to go about double the dose if the TSH level is about 20. You have to double the dose. The postpartum care, nothing much different. Thyroxine is safe during breastfeeding. And most of the mothers get back to the pre-pregnancy thyroxine dose. And now we know in Sri Lanka, the neonatal TSH screening is universally done. And let's have a few slides on hyperthyroidism during pregnancy. Definition is as same. Reduced TSH and elevated TiO. It's a trimester specific values. There are maternal and fetal outcomes are listed here. And the causes, I would like to highlight one important thing. The gestational thyrotoxicosis is not an unheard, unknown. It is a gestational because we know that the HCG stimulates thyroid gland. So therefore, overstimulation can cause little thyrotoxic features even in a normal mother. So that is called gestational thyrotoxicosis. Others are the Graves' multinodular goiter and the toxic adenoma. And this table give a good comparison of the gestational thyrotoxicosis versus Graves' disease. And important things are if somebody has very frequent and too much of vomiting, that is more likely to be a gestational thyrotoxicosis. And the test to go by, if you want to make a differentiation, is a TRAB, the thyroid receptor antibodies, or thyroid peroxidase antibody, which is more likely to be positive in the Graves or autoimmune form than the gestational form. It is important to make the differentiation because gestational thyrotoxicosis does not need antithyroid therapy. It can be managed with supportive management, with hydration for vomiting and beta blockers for beta symptoms, and no ATDs are required. Graves' disease, the exacerbations of symptoms during T1 quite expectantly because of the effect of the HCG, but later on they get resolved. If you really want to make the diagnosis of Graves, check on TRAB. It has a value because then if the TRAB is positive, you can do advanced fetal monitoring to improve the fetal outcomes. So what to do? You attain euthyroid during pregnancy if it's the hypothyroidism in pregnancy. And first line antithyroid drug is propylthiouracil, and you can, due to cost factor or anything, change over to carbamazole in T2 or T3. Start the lowest dose, unlike in other situations. Monitor with a free T4. And if there's a persistent toxic features, you may have to do a TRAB in order to see how severe this thyrotoxicosis. Now, postpartum thyroiditis is another category we need to know. But its definition is very vague. It's a thyroid dysfunction 1 year postpartum in a woman without clinically evident thyroid disease before pregnancy. Usually they are TPO positive, and they differ from Graves' disease by TRAB negative. So in the want of time, I will just quickly go through the take-home messages. So TSH cutoff values are lower and trimester specific, not 0, 4 to 4. And subclinical hypothyroidism is the commonest thyroid dysfunction during pregnancy. Check TPO in expectant and pregnant with subclinical hypothyroidism. After you first diagnose subclinical, then check TPO. And thyroxine therapy has been shown to improve outcomes, both maternal and fetal, in the TPO positive subclinical hypothyroidism, not TPO negative. And during early pregnancy, exclude gestational thyrotoxicosis, which only needs supportive therapy, no antithyroid drugs. And propyl thyroxine is the first choice antithyroid drug for preconception, Graves, and all other forms of thyrotoxicosis. And checking on TRAB may be useful in some thyrotoxic mothers to improve maternal and fetal outcomes. Then you can refer the fetus for more advanced monitoring to prevent the fetus being born with hypothyroid state. Thank you.